first slide is really to describe that there are some specific characteristics about uveal melanoma compared to some of the other cancers that we use immunotherapy, and that's the fact that uveal melanoma, not surprisingly, has much less in the way of mutations or damage compared to skin melanoma, which is right at the other end of the spectrum in terms of cancers. Skin melanoma obviously is very damaged from ultraviolet radiation. So that's one of the reasons that is used to explain why immunotherapy works better in melanoma, and conjunctival melanoma on the surface of the eye actually behaves more like skin melanoma because, again, the ultraviolet radiation damages the surface of the conjunctiva. There are very few mutations in uveal melanoma, and also it's a tumor that has very low levels of PD-L1, and PD-L1 is actually a target for one of the immunotherapy drugs, class of drugs, whereas it's much higher in skin melanoma. So again, another reason why these drugs work better in skin melanoma. So we've had a big shift in the last 10 years in melanoma therapy. There are about 9 different drugs now approved, but really immunotherapy is the main class of drug that we use in uveal melanoma. The other drugs are not really helpful because of the lack of mutations. But in fact, immunotherapy goes back over 100 years ago. So you may have heard of Cooley, who was a surgeon in Memorial Sloan Kettering in the 1890s, and he actually treated patients with cancer, with a host of cancers, mainly lymphoma and sarcomas, because that was his main practice, by injecting those patients with a cocktail of bacteria, 2 different bugs, and as you know, not surprisingly, patients got quite sick, got blood poisoning from the cocktail of sepsis that he induced. But he actually noticed quite a lot of these patients did quite well long term. We had very few melanoma patients, but some patients were going out to 20, 25 years with apparent evidence of remission of their cancer. And this has led over the next 100 years to increasing interest in immunotherapy. And as we know, the Nobel Prize for Medicine last year was given to 2 scientists, science physician. One was Jim Allison in Texas and Tasuku Honjo in Japan. And they both, Jim Allison described the CTLA-4 pathway and Tasuku Honjo the PD-1 pathway. And you can see that melanoma survival has actually shifted dramatically. That was the first drug, ipilimumab, which doubled long-term survival out to 10 years. And on the bottom right there, you have a cartoon showing one of the sort of side effects of immunotherapy, because these drugs boost the immune system, but the immune system can also recognize normal cells as foreign, and you get allergic reactions as part of the side effects. And in fact, there's some link that if you do get more side effects, you may have a better outcome. And I'll come on to that later in the talk. At the top right, there's a cartoon showing very simplified form the immune system, basically cells that engage the foreign antigen, whether that's a bacteria, virus, or a cancer cell, and they provide the information to the foot soldiers, the T cells, and those are the cells that go out and basically seek out and destroy the cancer cells. But we know that in many cancers, these mechanisms are not really working very well for various reasons, which we're still trying to decipher. There are many other molecules, as you can see in this cartoon, that are being studied to try and find other drugs beyond what we have at the moment in the clinic, and many of those are still in early phase clinical trials, but it's hoped that more studies and combinations in patients will lead to better outcomes across a whole range of cancers. These diagrams essentially highlight the dramatic advances that have taken place, particularly in skin melanoma, and you can see at the top right there, really the gold standard treatment now, particularly for aggressive melanoma, is a combination of ipilimumab and nivolumab, and we'll have the 5-year data this year, but it looks like we will have about 50% of patients with advanced cancer, and that includes patients with brain metastases, liver metastases, and so on, surviving 5 years. So, you know, a five-fold increase at 5 years. It used to be below 10% at 5 years. Now it's approaching 50%. So that's really an amazing advance. But what about uveal melanoma? So it's classified as a melanoma because it develops from cells as pigmented cells in the skin, producing melanin, although they don't always express melanin. This is a patient with metastatic involvement of the liver with uveal melanoma. So about 50% of patients will develop this problem over the lifetime of their disease, and death is usually due to liver failure, essentially, as the tumor takes over the liver. And many studies have shown, pre the era that we are at the moment, that median survival is around 6 to 12 months. And survival at 1 year has been quoted at being around 10%. But I think, as you'll see, that there is studies are now showing that we are beginning to change those metrics. So one of the first drugs, the one Jim Allison developed, ipilimumab, this was tested and published in 2013, and it didn't show the same sort of prolonged responses as we've seen in cutaneous melanoma, but in terms of median survival, there was the same sort of 4 months improvement. And out to when this study was published, we had about 20% of patients alive at 1 year. But you can see the response rate was really quite low, 5%. In fact, that's what you get in skin melanoma. You also get 5%. So, you know, it looks, on balance, if you look at data to 1 year, it looks very similar to cutaneous melanoma. But in fact, the 20% survival you see there, that actually reduces over time in uveal melanoma, whereas in cutaneous melanoma, I've shown you on the previous slides, actually maintained out to 10 years now. It seems once you get onto that 2-year curve, you stay alive and well with prolonged remission, probably cure. So, you know, the drug has some activity, and in fact, that was the drug that we've been using up until recently in clinic as our frontline therapy in a patient with disease that wasn't resectable in the liver. Pembrolizumab or nivolumab, which are the PD-1 drugs, actually work less well. In fact, the response rate is lower than 5%, and you can see very small number of patients are getting shrinkage. This is one sort of unusual patient that has had treatment for 2 years with pembrolizumab in this study. So these drugs working less well, but yes, in some patients, they do have a role, and we've certainly seen patients at Bart's out to 2 years, not many, but on single agent pembrolizumab. And you can see that actually median control of the disease is only 2.6 months, and the median survival in this patient was less than ipilimumab, so it was 7.6 months. So what about the combination? So this led to very striking shrinkage in patients with cutaneous melanoma. So 60% of patients with advanced melanoma had very marked reduction of the disease, and you can see very sustained remission. So this was approved in September 2016 in the NHS, and I met a patient who walked through the clinic at Bart's, referred to me from Moorfields. In fact, he's in the room, I'm delighted to say. And he had a classic scan showing multiple liver metastases, very much what you saw on the picture there at the operation at laparotomy. Multiple liver metastases. You can see a large one there, which was several centimeters in size. And I gave him the option of ipilimumab, which is what we've been using for the last few years, and said, well, NICE have just approved combination immunotherapy with ipilimumab and nivolumab. So I said, go away and have a think about it, because the side effects are actually, if you're aware, significantly more side effects with the combination. So instead of getting 10% serious side effects, up to about 50 to 60% serious life-threatening side effects, which are usually reversible with steroids, but still, that's a significant risk of hospitalization from side effects. And we got the phone call back on Monday to the clinical nurse specialist saying, I'd like to have the combination, please. So this was our first patient, at Bart's. And as often happens in these things, the first patient you put on a particular treatment, they generally do quite well. So Russ, who had this treatment, actually had a profound response. So we wrote him up as a major responder. And you can see here, LDH is a marker you can measure in blood. It's one of the highest I'd seen. It was 6,000, which is, very, very high. And within 50 days, it plummeted to normal as he went through the first 4 cycles of combination immunotherapy. Unfortunately, well, actually, maybe fortunately, because as I was saying, side effects seem to be related to how well you do in some of these patients. He developed several side effects in sequence. So first of all, got a bit of liver inflammation, which wasn't too serious and settled down. We didn't need to treat that, but sometimes that can actually stop you from using any more immunotherapy. But more seriously, he then landed up in hospital with a very high sugar, sort of semi-conscious, with basically new diagnosis of insulin-dependent diabetes. So the immunotherapy had essentially wiped out his insulin-producing cells. And at that point, we stopped treatment temporarily and until we got control of the sugars with insulin. And he carried on with another 2 cycles at that point, just of nivolumab, because you have initially 12 weeks of the combination, and then you move on to maintenance therapy with nivolumab. But then I get a message that Russ can't see anything now. He's gone blind. So basically, the treatment then attacked his good eye, and he got a uveitis. So that needed urgent treatment with steroids. He had topical steroids, some oral steroids, and that settled down. But really, at that point, we decided to call it a day with the immunotherapy. And actually, on subsequent review at Moorfields, it was noticed that the tumor that had 5 years previously received proton therapy had actually depigmented. You can see those black areas of melanin. So this is an irradiated melanoma. There was no evidence that it was active at that time, but you can see the pigment disappearing on the immunotherapy. It's a similar situation. Patients can get vitiligo on immunotherapy as a marker of response. And he's currently coming up to his, in August will be 3 full years, having had just 3.5 months of treatment. In fact, the studies at that time suggested there was a German cohort of compassionate combination therapy, that the response rates are around 15 to 20% in this in patients with uveal melanoma, which is 3 to 4 times higher than standard monotherapy. So we're now into 35 months and very low levels of LDH, and there's Russ' picture of health enjoying a walking holiday. So, this has now become our standard treatment now. Patients who come through Bart's, they're offered combination immunotherapy. Obviously, it's sort of maybe biased by our first patient who had this experience, but in fact, there's now data, as I'll come on to show you, that actually confirms that this is a more active treatment and has a better outcome in terms of median survival, although it's not randomized data. This is another patient actually who's written up as a single case report from Georgetown in the US. So this is again a patient, he actually had a complete response. So all the melanoma disappeared on the scan. He also got quite a serious allergic reaction, which Dr. Aurora can tell you a lot more about, Vogt-Koyanagi-Harada syndrome, which involves uveitis, tinnitus. You can get a bit of inflammation of the outer layers of the brain, meningitis. He also had really quite marked inflammation of the bowel. So he required prompt treatment with steroids. In fact, the steroids didn't reverse the bowel problem, and he had to have second and third class of drugs to reverse the diarrhea. So he had 24 months of complete remission until at which point the disease returned, and sadly that patient died. But the scientists, physicians did quite a lot of analysis of his the T cells in this patient, and the ones that they found the ones that were attacking the tumor were also the same ones that were attacking the gut. And they identified a particular clone and showing that the T cell was quite specifically being redirected in some respects to attack the melanoma in that patient. So this is hot off the press. This was presented last month in Chicago at a big cancer meeting called ASCO. And this is actually a study that took several years to complete at MD Anderson, and a similar study was completed in Spain. In fact, the target population was 50 patients, but in the end, the data was presented on 35 patients. And you can see that in this group of patients with metastatic uveal melanoma, the progression-free survival has shifted from the historical around 2 months with chemotherapy, which is what you'd expect with dacarbazine, to 6 months. So, tripling in the progression-free survival. And you can see that at the point that Russ is at, actually most people have already progressed, and it's only between 5 and 10% remain progression-free, which means they've got perhaps disease on the scan, but it's not doing anything, and that's out to about 4 years. But what's also interesting is that the median overall survival, which, as I've said, historically is 6 to 12 months, is now been, this is not randomized data, but in this phase 2 study, comes out to 19 months. And in fact, we've got data being presented here 3 to 4 years, and over a third of patients remain alive. So these patients may have progressive disease, but they're probably accessing other treatments, other trials, etc. So what about other immunological approaches, so boosting the immune system? This was published very recently, actually work that's been going on for several decades at the National Institutes of Health in Bethesda in the US. So you may have heard of Steve Rosenberg, who's been working in this area a very long time. So he removes tumors from patients, extracts the T cells that are already in the tumor, grows them up, and then the idea is they get reinfused back into the patient, very high concentration. And in fact, in this study in patients with uveal melanoma, responses were seen, as you can see here, in patients who had previously had immunotherapy with the ipilimumab and the PD-1, PD-L1 drugs. So this is something that's ongoing work in the US, but certainly seems to have a role for some patients. But this is really within an academic context at the moment. The other thing is there's a lot of interest at the moment in developing personalized vaccines, and I think this might be a possibility in future if you can find critical antigens where you can develop a personalized vaccine. And this is really proof of principle that was published in Nature 2 years ago by Ott et al. And these were patients who had, it was actually a small study, but they found that by injecting patients with peptides, so small segments of protein that was basically done to stimulate an immune response against the patient's melanoma. And these are patients who had progressed on checkpoint and then had, so these are 2 patients shown here, and then had a response when they then had their personalized vaccine. So this is the Neovax approach, and there are sort of similar interest by other companies to develop this approach further. And I guess the big current player in this area, redirecting the immune system, is Immunocore with IMC GP100. So this is actually a soluble molecule that essentially is designed to link the T cell and literally drag the T cell to the surface of the melanoma cell. And this works in patients that have a particular blood type, so HLA-A2, and express the protein GP100. So that's supposed to be around 50% of the population. And these patients are then given this drug. And we had a press release this time last year in a small study of 19 patients, which I'll go on to show you some more data, but this is really the bullet point. And where they analyzed response in these patients, they also found an objective shrinkage, so 30% or more shrinkage of around 18% in this population of patients. And the survival was quite promising in this small study of 74% at the time that cutoff analysis was done. So it's an intriguing way of homing the immune system directly into the liver to attack the uveal melanoma cells. So this is the molecule that's been designed, and you have a portion here that binds to the T cell, so to the surface of the foot soldier, and this is the bit of the molecule that attaches directly to the melanoma cell. And once you've got that physical engagement, that allows the T cell to then send death signals to the melanoma and induce what's called apoptosis, which is shown here with this sort of ultra-high photography here. You can see the T cell latching on to the cancer cell, and you can see it's actually not looking very healthy. It's sort of got all these blebs and basically the plasma membrane's falling to bits. So that's how this the treatment works. So it's really quite a novel way of approaching cancer immunotherapy. So this was the study that was presented, and you can see quite a lot of these patients. So it was a caveat is this was a small study, but many of these patients had had prior immunotherapy, either with ipilimumab, nivolumab, or pembrolizumab. Some patients had had chemotherapy, so really quite heavily pre-treated patients. And the other point to note is that 3/4 of them had elevated LDH, which is usually a very poor prognostic marker in these patients. And pleasingly, about 2/3 of the patients had shrinkage of disease, and the sort of magic figure of 30%, that was an 18% response rate in these patients. And here we have the overall survival, which actually hadn't been reached up until the data cut point, which was 19 months. So over 50% remained alive. And also, intriguingly, I mentioned skin toxicities being linked to response. So it was noted in this small study that patients who developed a skin toxicity, so a dermatitis, redness of the skin, or itching of the skin, these patients had a better survival than those patients who had no skin rashes or no allergic reactions. In fact, I've seen that in some patients being treated with ipilimumab or combination immunotherapy in my practice. Skin toxicities seem to also link or associate with better outcomes in those patients. So this is the current randomized trial. So to get a new drug approved, you have to compare it to whatever is the standard of care. And actually, uveal melanoma, depending on which physicians you ask, the view is that there is no standard of care. So in this particular study, the randomization is either to IMC-GP 100, so the immunocore drug, versus investigator's choice. And the three options there are either ipilimumab, either PD-1 blockade, so nivolumab or pembrolizumab, or the old-fashioned chemotherapy dacarbazine, but not the combination immunotherapy in this study. So one area that I'm particularly interested in, I am interested in immunotherapy, but actually I've come at looking at uveal melanoma from a metabolic approach. So a nutritional approach is essentially to starve melanoma of a nutrient, arginine, which is present in many foods. And the idea is that some cancers, including uveal melanoma, lack the ability to make arginine, so they feed on arginine from the bloodstream. And essentially, if you remove the arginine using a drug, and here's an enzyme which starves or basically converts the arginine into other molecules, so citrulline. This, in this context, this leads to killing of the cells, and it works very nicely in the Petri dish and also in mouse models, and there are some clinical trials looking at this approach. In fact, we recently completed a study of arginine deprivation with a drug called ADI-PEG20, combined with two drugs which are not normally used in uveal melanoma, but essentially this was a bolt-on study to our main program, which was in patients with lung cancer and mesothelioma. So we treated 10 patients. Again, the majority, 80%, had previously had ipilimumab. Around 70-80% had high, 70% had high LDH levels, and we showed that the drug could reduce arginine. For the study, there was some some arginine did come back in the patient's plasma due to a neutralizing antibody response, because the drug is actually formulated from a bacteria, so it's foreign, so you do get a neutralizing reaction. But we did see in this quite heavily pretreated population a median overall survival of almost 12 months. So this particular work is now moved into a new study at Memorial Sloan Kettering, New York. So it's a small study, and because of other data in mice, this study is actually combining arginine deprivation with the standard immunotherapy, but actually the lower dose of ipilimumab. So a regime that's called Ipi-Light, essentially to try and reduce some of those more serious side effects. And I'm pleased to say that we've been given the green light to do a parallel study in the UK, and that probably, hopefully by the end of this year, early next year, called Atomic B, and that's the same 3-drug combination, but actually we'll be using the standard NHS-approved doses of ipilimumab. So, we expect more toxicity, or perhaps less, if you combine it with arginine deprivation. And that's a study, as I say, we hope to open soon. That'll be specifically for patients for uveal melanoma. So just briefly, as I'm running out of time, is just to mention some local regional treatments. You'll be probably familiar with Delcath. So infusing high-dose chemotherapy with melphalan, and this led to a quadrupling in the control of the disease, so from the expected 2 months or so to 8 months. And there was really quite a high shrinkage rate of around 34% in this study, so a third of patients had shrinkage, but there was no difference in survival, because patients who got the control treatment, which could have been immunotherapy or chemotherapy, were then crossed over to receive Delcath. So this has led to the current FOCUS trial being done in 3 centres in the UK, and that's to see whether there's any additional data that can be gleaned from this to lead to an approval more formally in the NHS and more globally. So that's something to watch. Intralesional therapy with a virus, RP1, with and without immunotherapy, is currently being looked at in uveal melanoma as well. So this is involving direct injection of a virus that's been tweaked. And this is being done at the Marsden, Professor Harrington, and also Dr. Sacco in Liverpool. And that's really their program. They're actually designing 2nd and 3rd generation viruses called RP2 and RP3. So in summary, I hope I've shown you that there are increasing options for treating patients with uveal melanoma, but obviously we have a long way to go. My view is that combination immunotherapy is really what we should be offering patients, although in the context of specifically HLA-A2, I think if a patient is HLA-A2 positive, then I think the Immunocourse study is really a very good study for patients to be enrolled into. So I've mentioned IMC GP100, which now has the name of Tebantus-Fusp, a bit of a mouthful. And then there are local regional treatments. I haven't really gone into radioactive beads or SERT with yttrium, which is another approach. Some patients can do well with radiofrequency ablation, and I mentioned the RP1 viral approach. So, it remains a high area of unmet need. Uveal melanoma, obviously, we need to move the long-term survival responses up to cutaneous melanoma levels, and I think we need to do that by focusing more on the biology of the disease, which is pretty unique compared to skin melanoma. Thank you very much for your attention.
I know that you need to shoot off, so mindful of time, so really however many questions you're able to answer for us as they pop up shortly. And I think that was quite a whistle-stop tour. Only half an hour to go through all of the types of treatments is a big ask. But we're going into more detail tomorrow, so if you do feel that you've been bamboozled, videos will be out in a couple of weeks' time, and 2-3 weeks, something like that.
And do please talk to Russ, because he's been through the treatment, so I can tell you all about it.
Yeah, and then if you're happy just to pick some questions that you feel comfortable to answer now, otherwise we can send them to you.
If you're allergic to all steroids, well, generally you're not allergic to steroids. I have heard of the odd patient allergic to steroids, but steroids are usually used to treat allergies, so it's quite unusual. although I did come across a patient recently who did claim to be allergic to steroids. I think the problem is if the steroids don't work and you develop an allergic reaction, what do you do next? So there are other drugs. They're usually drugs designed from the transplant area of medicine. So, you know, drugs like mycophenolate, azathioprine and others. So that's where we go if steroids don't work. I don't really, you know, I'm pretty agnostic as far as ultrasound or MRI is concerned. I mean, generally, MRI is considered the gold standard for imaging of disease. We use CT when we're monitoring for metastatic disease, unless there's a particular issue of concern, and that's partly because of capacity within the NHS. I think ultrasound in good hands can be useful for surveillance if we want to discuss that point, but it has to be somebody who's very experienced at using ultrasound. I've had the odd situation where ultrasound has actually picked up metastatic disease more readily than MRI, but the patient that I'm particularly thinking of was basically had panic disorder and couldn't go into an MRI, so had an open MRI, which is not as good as a closed MRI. So the ultrasound there picked up suspicious disease before the open MRI. So I don't think open MRIs are particularly good. Are there any trials for non-metastatic patients following radiation therapy? So actually they are starting in the US at the moment. So Dr. Satna Patel, who had that poster at Chicago this year, I know they're planning and may already have launched an adjuvant study of Ipi-Nivo. She did do a high-dose Ipi study, 10 milligrams per kilogram, which is actually 3 times the standard dose. A lot of patients actually developed serious side effects. You know, there were episodes of patients going blind, and that study was actually stopped by Bristol Myers Squibb. They didn't support that trial anymore. But I think the 3 mg of ipilimumab with nivolumab adjuvant for monosomy 3 patients, the ones that we know have very high risk of relapse, I think that's, you know, an area where I think we need to do the studies and optimizing with other approaches. Local treatments are available for lung mets. Yeah, so radiation, I guess CyberKnife, if it was very limited, you know, we do discuss those patients occasionally in our lung MDT. Specific diet should we be following? Well, I think it's quite interesting following the overweight question, because actually in melanoma, there are data to show that overweight, obese people do better than thin people with on immunotherapy. That's specifically in, just to throw the cat amongst the pigeons. So, yeah, you might, generally being fat obese is not a good idea for cancers. But this is a very interesting area of research. It's all to do with the gut, the bacteria in your gut. There are also data that came out from Chicago a few years ago. The microbiome is influences, and they've done those studies in mice. So it's replicated what they've shown in humans is if you remove stool from certain mice and put it into the back passages of mice, and you can change the bacteria, the microbiome, you can actually improve responses to immunotherapy. So I don't suggest you start doing fecal transplants or anything like that. But I think it's a fascinating area of research. And on many of these studies, in fact, in one study we're hoping to open soon with the arginine deprivation and immunotherapy, we're also going to be asking patients for their stool samples for analysis. So that may be related also to the overweight obesity question. I think I'm going to have to stop it there.
Yeah, just one question actually that comes through is now that we're starting to see more people having Ipi-Nivo, if they do have side effects and they're in then a local hospital, do they need to be very careful with antibiotics?
Yeah, well, that's an interesting question. So that's right. There are data, particularly in lung cancer more, that patients don't respond so well to immunotherapy if they have antibiotics. But the jury's still out on that. In fact, you could have bad bugs in your gut. So if you take antibiotics and eliminate those, you might actually have a good response. So I think, you know, the studies need to be done, but I'm very cautious actually about immunotherapy. I treat a lot of patients with lung and mesothelioma as well, and that comes up quite often because those patients are more likely to get pneumonia or chest infections. I don't think it's such an important an issue in melanoma because patients generally are fitter. But yeah, I always am a bit careful about that. I mean, obviously, if you have a serious infection, you've got to take the antibiotic. It's a bit like the Cooley's toxins, you know.
he treated patients by giving them bacteria, you know. So it's not what we do today, but there is some sort of link, I'm sure, with bugs and the immune system and
Would
cancer.
it be good to keep the medical oncologist involved if
I
they're
think
feeling
so, yeah. I
poorly on
think it's best to
immunotherapy?
let them know, yeah. And also steroids, there are data now coming out that, you know, treating patients for a prolonged period of time with steroids might also influence outcome of immunotherapy. It wasn't thought to be so important before, but I think there are some data, particularly from the meeting in Chicago, that was beginning to suggest that.
Fantastic. Thank you.
Thank you
I
very
really
much.
appreciate your time. Thank you.